Olá a todos, boa noite, obrigada pela participação de todos aqui. É sem dúvida um momento especial para o Portal Doctor realizar esse trabalho para vocês, com a presença do Dr. Aria Fallah, que muito gentilmente aceitou o nosso convite para esse momento de troca de conhecimento, porque a gente sabe e entende da importância dos diversos países em conjunto, trocando sinergia de conhecimento. A gente está sempre apoiando isso. E não deixem de, ao final da aula do Dr. Aria, fazer as suas perguntas, participem. Convidamos hoje o Luiz Gabriel Duarte, da Universidade Sapienza. Ele está aí à disposição dos senhores exatamente para fazer esse intercâmbio, essa intermediação dessa importante participação dos senhores na aula do Dr. Aria. Também lembrando que ao final a gente vai ter a participação do nosso apoiador da Surgery, fazendo uma apresentação para os senhores. Então estamos juntos, eu estou aqui acompanhando. Uma boa aula a todos e até já.
Thank you very much, Sheila. Dr. Fallah, whenever you're ready, we can begin the lecture.
Okay, great. Thanks. Thank you, everyone. Happy to be joining you from Los Angeles. I wish I could be there in person, but happy that we can at least do this. And thank you for the invitation, and Luiz for organizing this. So today, making sure everyone can hear me, correct? Okay, great. I'm going to talk about the evolution of hemispheric surgery for treatment of drug-resistant epilepsy. And I have no conflicts of interest. So we're going to talk about a few things: definition, history, indications, patient evaluation technique, and some of the postoperative nuances of hemispheric surgery. By definition, hemispheric surgery is any type of operation where the goal is removal or disconnection of an entire cerebral hemisphere. And I'm going to talk to you briefly about, there's many different variations of techniques that exist. The ideal candidate for this procedure is a child under the age of 2 with lateralized, medically intractable epilepsy, and preferably with contralateral hemiplegia and hemianopsia secondary to damage already in that hemisphere. These are the best candidates for the operation, have the best outcomes, and the least likely to have any new neurological morbidity as a result. The history of cerebral hemispherectomy is quite fascinating. In 1928, Walter Dandy first reported the use of hemispherectomy for patients with brain tumors, actually, with a glioma. All of them had symptomatic improvement, but eventually all the tumors recurred on the opposite side. It basically taught us a little bit about gliomas, that they're not a hemispheric or lateralized disease. In 1938, K.G. Mackenzie from the University of Toronto was the first to actually perform a hemispherectomy in a young child and noted benefit in terms of seizure control. It was actually done for spastic hemiplegia, but he noticed that the seizures improved as well. South African neurosurgeon Ronald in 1950 reported outcomes on 12 children that had a hemispherectomy and reported a dramatic reduction of seizure frequency and significant improvement in cognitive and behavioral outcome. It was in the 60s when Oppenheimer and Griffith reported great outcomes with seizure freedom, but then determined that some of these patients go through a gradual neurologic deterioration with seizure recurrence. And this was, if you look at this, this is a pneumocephalogram. Looks like essentially this child has developed untreated hydrocephalus. Some of these patients on autopsy study would found to have superficial cerebral hemosiderosis as a result of persistent intracranial bleeding. This is something we see less commonly now, but it's well described in the hemispherectomy literature. So starting with an anatomic hemispherectomy, this is what you start off with. This is a child with an MCA stroke. You can see the area of gliosis and encephalomalacia in the perisylvian region. And this is what you end up with looking at the falx, tentorium, all the way around with only the midbrain structures, brainstem structures intact. This procedure has the highest risk for significant blood loss. In actual old series, you will actually even have a very few patients that may have died from catastrophic bleeding, generally associated with anatomic hemispherectomies. Fortunately, that's quite rare these days. It does have the highest risk of hydrocephalus, estimated to be about 30%. But it is the most certain procedure, obviously, to disconnect this hemisphere, as you can see over here. In our experience, this is really indicated for persistent seizures after a functional hemispherectomy. Almost all patients initially get a functional hemispherectomy. The evolution of hemispheric surgery has focused on less brain resection and more on disconnection of the epileptogenic cortex, really as a way to improve perioperative complications and long-term morbidity. Theodore Rasmussen from the Montreal Neurological Institute in 1974 was the first to describe an operation where you performed a large central resection, an extended temporal lobectomy, and through this, you disconnected the rest of the hemisphere. So this was a improvement on the anatomic operation because there were significantly less blood loss. And over the years, we've removed less and less brain and disconnect more and more. This is the initial procedure, 1938, by Mackenzie. Rasmussen's evolution, 1974, the functional hemispherectomy. In 1995, the peri-insular hemispherotomy was described by Villemur. Professor Delalande from France described the vertical parasagittal hemispherectomy. And actually, in North America, most of us do the lateral approach. Some other places in the world, particularly Europe, they do the parasagittal hemispherectomy a lot more over there. It doesn't really matter as far as we know which technique you choose, as long as you do it well. 2001, Johannes Schramm described the transsylvian hemispherotomy. And very recently, by Professor Chandra in the All India Medical School in Delhi, as well as Professor Sandeep Sood from Michigan Children's Hospital, described the endoscopic assisted hemispherotomy that is becoming a little bit more popular these days. But there's well over 15 different techniques of hemispherectomies described and many variations of this procedure. This is what the endoscopic corpus callosotomy hemispherotomy looks like. It's not done through an endoscope, it's just endoscopic assisted for visualization. So you're really doing all the same steps just through a smaller skin incision and craniotomy. Recently, there was a case report of a endovascular embolic hemispherectomy. So this is a patient with hemimegalencephaly of the whole hemisphere in a young neonate that was having multiple seizures a day. But the child was deemed to be too young to perform a traditional open procedure. So they staged this by performing a endovascular embolic stroke on the unilateral side, and then followed later by a hemispherectomy procedure. So stepping aside, briefly talking about catastrophic epilepsy, what is it? This is the type of epilepsy that tends to present in the first year of life, and when you talk to some of the mothers, they report seizure-like episodes of their fetus when the infant was still in utero. The epilepsy tends to be very severe, very intractable, daily, often multiple seizure types, and can have status epilepticus. And these patients can have delayed cognitive development or regression, motor function may be impacted. So in terms of timing of surgery, when is the best time to perform this? And the answer is as soon as possible. Generally, these decisions get made in a patient management conference. We think about symptomatic progression. We think about the age of the patient in terms of development as well as neuroplasticity. The younger they are, the greater the ability to rewire their brain. Traditionally, 6 kilograms was the cutoff in which we would not perform a hemispherectomy on a younger child because of concerns for blood loss. but I think we're sort of pushing the envelope now. So the youngest child I've operated on has been, I think, just 5 kilograms, but there's also been a report of a child 8 pounds in weight. So that's pretty small. I think that's 3 and a bit in terms of kilograms. You know, the most important thing is you can remember, even if the child is really young, you can always stage the operation. You don't need to do it all at the same time. So this can be done quite safely as well. And ultimately, it's a life-saving procedure for some of these children. If they have, you know, up to 100 seizures a day, sometimes they have apnea associated with the seizure episodes, you know, you're sort of forced to go in sooner. One of the most common indications for hemispheric surgery, so in terms of malformations of cortical development, hemimegalencephaly, which is actually the most challenging lesion to do hemispherectomy on, as well as hemispheric cortical dysplasia, a rare condition called Sturge-Weber syndrome, MCA strokes or porencephalic cysts, and also autoimmune encephalitis, particularly Rasmussen's encephalitis. Very briefly about malformations of cortical development, these are generally congenital lesions, can have a genetic component to it, and these patients tend to have severe refractory epilepsy. This is the classification of FCD, the Blumke classification. Essentially is a abnormality in the architecture of the brain in terms of the laminar organization of the brain. With type 2, you also get dysmorphic neurons, and type 3 is basically focal cortical dysplasia associated with other pathologies, other hippocampal atrophy, tumor, vascular malformations, or other lesions. There's a multitude of genes that have been described being related to various types of malformations of cortical development. One particular condition, hemimegalencephaly, is a rare congenital disorder generally affecting one part of the cerebral hemisphere. Here you can see a very enlarged right hemisphere with abnormal gyration and sulcation patterns. It has been linked to somatic activation of the AKT3 gene pathway. These patients generally present the youngest with the most severe forms of epilepsy associated with contralateral hemiparesis and severe psychomotor delay. And there are some groups that actually advocate for upfront anatomic hemispherectomy for these patients because of the challenge in getting a complete disconnection using a functional approach. And cortical dysplasia, as you know, these can have very subtle features on an MRI, and generally looking at blurring of the gray and white interface, or focal cortical thickening, or a transmantle sign. These are the clues, but also specifically in type 1 cortical dysplasia, these findings can be extremely subtle and sometimes invisible on the MRI. Porencephalic cysts, this is what they look like. These are usually patients that have had a perinatal vascular insult from ICA or MCA infarct or a large hemorrhage. They may have seizures at the time of this event, but generally they don't become drug resistant until a little bit later in life, usually somewhere between 5 and 10 years of age. And the seizures generally at that point become medically refractory. This is what the brain may look like, a large porencephalic cyst. In these patients, quite often the normal functional aspect of the contralateral side has already shifted over to the other half of the hemisphere. So these patients actually do quite well after hemispheric surgery and sometimes don't have any additional deficits. Lastly, Sturge-Weber syndrome is a neurocutaneous disorder that's progressive. It's congenital. It's characterized by a classic port wine stain on the face in the trigeminal nerve distribution, generally on the same side as the intracranial findings. Intracranially, progressive cortical calcification, atrophy of that hemisphere. This is what the brain may look like during surgery. We have to be careful during surgery because the vasculature is not normal. The tissue is actually very friable. so higher risk for blood loss, but a certain proportion of these patients will also require hemispherectomy. And this is what it looks like. So this is a patient. This is what the brain looks like 3 days after birth, several years later, and then this is the latest scan, and you can see the progressive atrophy, the abnormality, and the myelination pattern on the left side of the brain. This is a very classic finding on X-ray. It's called tram track signs. It's what it looks like because of the progressive calcification. Generally, this is unilateral, but this is a patient that has bilateral evidence of Sturge-Weber. And lastly, Rasmussen's encephalitis is an autoimmune condition, generally leading to progressive hemiparesis, hemianopsia, cognitive difficulties. Generally starts in children under 15 years of age. There are some classic papers on Rasmussen's encephalitis, basically talking about how some patients are fast burners and some are slow burners. For certain patients, the onset is at a much younger age, and they have much more severe surgeries, severe seizures right away, necessitating a hemispherectomy much sooner. And for other children, it presents a little bit later in life, and it's generally a much more indolent course as well. But pathologically, we see brain inflammation characterized by infiltration of T-cell lymphocytes. Neuroimaging shows progressive brain atrophy. Here you can see the left ciliate fissure is a little bit enlarged, and you can see some flare hyperintensity in the insular region. And this is what it looks like on serial imaging. You can look at this child, 2013, brain looks pretty much normal. 2014, you see larger CSF spaces around the sulci, further atrophy 2015, 2016, and here you can see a clear atrophy on the left side of the brain compared to the right in a matter of just 3 years. When we look at the UCLA series, now this is published several years ago, on about 100 patients or so that have undergone a hemispherectomy, we find that these patients are actually quite different. The hemimegalencephaly patients have age of seizure onset, as well as the hemicortical dysplasia patients, much younger compared to Rasmussen's and patients with infarcts. The patients that also undergo surgery are much younger in terms of hemimegalencephaly, as well as cortical dysplasia compared to the other two conditions. And infantile spasms are quite common in the cortical dysplasia patients as compared to Rasmussen's or in patients with infarctions. Status epilepticus, and especially focal status, can be quite common in Rasmussen's syndrome, as well as hemimegalencephaly. This is a patient I helped with. This is one of the youngest patients that were operated on in Chile, in Santiago. It's a 6-week-old that did a functional perinsular hemispherectomy, and sort of this is a year later. I don't think this video, I don't think the video is working there. This one's working. It kind of shows you this is what to expect a year out. Generally, patients are able to walk. You know, usually there's a limp. The most difficult functions to get back are intrinsic hand function, as well as ankle movement. Usually, a lot of these patients will still have a foot drop. This is another child with Rasmussen's encephalitis who had a functional hemispherectomy. You can see that their hand that's affected is more of a helper hand as opposed to a, being independent. But these children can, you can see here he's got an ankle brace, but he's playing basketball with his good hand, and there is some residual physical deficits, but these children dramatically do better from a cognitive standpoint after surgery. So traditionally, as neurosurgeons, we are told to counsel patients after hemispherectomy that they're going to lose some motor function and some visual function, and but that seems to just be a completely a complete underestimate of the deficits that these children face. A lot of them, this is a recent meeting we had in Cleveland with a lot of neurologists, neurosurgeons, speech language physicians, neuropsychologists, and so on, and really trying to understand all the problems that happen for these children to have a hemispherectomy. It's more than just what we talk about as neurosurgeons. A lot of them need orthopedic surgery in the future. A lot of them struggle with mental disorders, mood issues, depression, isolation. They have issues with sensory reception of, if, for example, if they're in an area with multiple sounds around them, they may have difficulty deciphering where this information is coming from. So they have central auditory processing disorder, language issues, behavioral issues, endocrine issues. A lot of them struggle. As neurosurgeons, we're always interested in hydrocephalus, but quite a large proportion of them develop hydrocephalus, requiring shunt management. So we're just starting to learn about all this. So I think as neurosurgeons, we have to be a little bit more cognizant of all the other things that are happening as a result of hemispheric surgery. It's still the best operation for a lot of these patients, but it comes at a price as well. One of the things we did was a multi-center study. This is some of my colleagues in University of Montreal, Sick Kids Hospital, to try to develop a hemispherectomy outcome prediction scale. As you may know, there's no good tool to try to predict outcomes following surgery. And obviously, one of the things we really want to try to avoid is a patient that has had a hemispherectomy surgery but still has seizures. I call them, the double losers, right? You've had the operation, still having seizures. So we wanted to do a really large study with 1,000 patients. We ended up recruiting more than what we wanted to, 1,267 patients from 32 sites from 12 countries around the world. And this is the breakdown of all the countries that, and all the institutions that provided data to us. And we found, first of all, this is the seizure outcome in terms of seizure freedom following hemispheric surgery. So close to 50% or so seizure-free at about 10 years following surgery. The 1-year seizure freedom rate that we quote, generally 86%, is what most studies quote, but it's really important to know that the long-term natural history is that the more these patients will have seizure recurrence. So I think just quoting 1 year may not be very representative. And going forward, we found a few things that are very predictive of outcome. One is non-dysplastic etiology, so dysplasia, so cortical dysplasia or hemimegalencephaly, those patients do worse than patients with other etiologies. Presence of infantile spasms, if you have infantile spasms, those patients do worse. In terms of the type of surgery, there appears to be a difference in terms of the patients with the vertical approach doing better, but this was not statistically significant, and this is something we're going to try to figure out in a future analysis of this data. And also, very importantly, presence of bilateral lesions. So if you only have an ipsilateral lesion on the MRI to the side of hemispherectomy, those patients do a lot better than the ones that have contralateral or bilateral lesions. This was a study from the Cleveland Clinic showing a large proportion of patients in terms of functional outcome after hemispherectomy will be able to walk independently, about 83% of them. Language is age appropriate in only a third of them. Only 53, only half of them have no behavioral issues. A lot of them will have some behavioral issues. And also in terms of being employed, 20% of them will have employment down the road. So these patients still have significant difficulties that they have to deal with in future years. Obviously, treating the seizures is most important, but these are many challenges that we're starting to now realize that these patients have many years following hemispheric surgery. So a recent article also came out showing how the function that is regained in the normal hemisphere following hemispherectomy, how that is organized and how these patients can regain function after a hemispherectomy. Reoperation is important. So for patients that have undergone a hemispherectomy operation, generally a functional hemispherectomy, and if they continue to have seizures, as long as you have no clear evidence that the seizures are coming from the other side, you may consider going back for a repeat operation, sometimes even when the MRI looks like there's a complete disconnection, because there are instances of that where we've been able to achieve seizure freedom as well. Generally, in this series, about 20% of them were able to achieve seizure freedom after anatomic hemispherectomy conversion. This is another study talking about the seizure freedom rates in adult and adolescent patients, as well as neuropsychological outcomes. And again, there's multiple domains. I'm not going to get into much detail, but these patients struggle with quite a bit of functional issues following hemispherectomy. I'm going to transition and talk a little bit more about surgery and sort of the subtle nuances of surgery. You know, most people here today are either neurosurgeons or training to be neurosurgeons. So, you know, hypovolemia is a really important issue. So you need to have really experienced anesthesiologists helping you with these operations. They can't fall behind on blood transfusion. And importantly, as a surgeon, if you feel that the anesthesiologist is falling behind, the safest thing is always to stop your operation. You can always either pause or abort it and you know, stage the operation, come back and finish it off the next day or the next week, and allow the team to catch up to blood transfusion. Because the only time when you see a really bad outcome or disastrous outcome with a patient that exsanguinates is in a situation where the surgeon's determined to finish the operation no matter what. So keep in mind, obviously, you'd like to do this operation all in one stage, but in the very, very young infants, they can be quite fragile, so you want to really take your time to do this. Aseptic meningitis is also known as chemical meningitis, is present in almost all the patients, right? It's just as a result of meningeal irritation due to the blood touching the CSF, can have a large variability in terms of severity and length of symptoms. These patients can present with nausea and vomiting. They can present with fever, headaches. Treatment generally is corticosteroids. Most of these patients I leave on steroids for about a week, but there's some that you have to continue for a week or so longer than that to try to really prevent that inflammation in the brain. Postoperative fevers can be common due to this. Placement of a postoperative external ventricular drain can really decrease and help with fevers. We think, there's not strong evidence, but we think that it can also lower the risk of requiring a VP shunt place. My criteria for removing the external ventricular drain after surgery is that the patient have no fevers, the CSF be clear, and the protein count less than 200. Infection, post-craniotomy, usually reported at 2 to 3% chance. Obviously, meningitis is important to rule out as well, and sometimes that can be difficult, determining what's chemical meningitis, which is quite common, and actual bacterial meningitis, which is quite rare but quite important to treat. Risk factors for meningitis is length of surgery, entrance into the ventricular system intraoperatively, and postoperative ventriculostomy. Also, we think about pulmonary complications, UTIs, and nutritional status in wound healing. Hydrocephalus is extremely important. Whenever we do this operation, we have to think about this because it is reported as common as up to 1/3 of patients. And I always say, I mean, we can always treat one lifelong condition, the epilepsy, but you don't want to leave the child with another lifelong condition, which is hydrocephalus. So there was a study, this was by Sean Liu, various institutions, mostly around the United States, that looked at post-hemispherectomy hydrocephalus in a multi-center study. we can see here that about just 30% or so of patients will develop hydrocephalus following hemispherectomy. They looked at several factors and tried to figure out what factors may predict the development of hydrocephalus. So anatomic hemispherectomy was associated with hydrocephalus development, whether or not the basal ganglia and thalamus were resected, whether there was a prior surgery, and use of some hemostatic agents. The factors that they looked at, they thought would be associated but were not, were postoperative infections, whether or not a postoperative CSF drain was used, and also the etiology of epilepsy. They also found that functional hemispherectomies lead to hydrocephalus 20% of the time, where anatomic hemispherectomies led to hydrocephalus close to 30% of the time. The presenting symptoms and signs of hydrocephalus was quite variable. Failure to wean the CSF drain was the most was common. Imaging changes, headaches. The other thing to remember is that some of these patients may just present with recurrence of their seizures, and it's very important to rule out hydrocephalus if the seizures come back. Here's an interesting case example. This is a child with a left MCA stroke. We did a hemispherectomy, developed hydrocephalus, and first we placed a shunt on the left side, but the shunt failed once I repaired it. The second time the shunt failed, I thought, why don't we go ahead and perform an endoscopic third ventriculostomy and, endoscopic, the video is not playing, but endoscopic third ventriculostomy and choroid plexus cauterization. And we were able to get a great flow void at the tuber cinerarium. And this patient's hydrocephalus was then resolved. And so he is now shunt-free for over a year, I should say. And so his post-hemispherectomy hydrocephalus was treated without a shunt. So always think about endoscopic third ventriculostomy options as well. The other thing we've recently studied is brain shift following hemispheric surgery. So this is what things would typically look like after a hemispherectomy. But every once in a while you have patients that have severe midline shift of the brain into the cavity. So one of the things they were interested in, and this is not well described, so no one knows, you know, we think there are no implications and no consequences of this, but this is very poorly described in the literature. So we looked at our experience and we found that depending on the etiology, there was a higher likelihood of this severe shift. So patients with strokes had a much higher likelihood to have this compared to, for example, dysplastic syndromes. We also suspected that patients that have a shunt on the side of the cavity may be more prone to having brain shift towards that side, and we found that as well. This was significant. So when there was a shunt, the shift was much worse. And also we found that when there was a non-programmable shunt, the shift was worse compared to when there was a programmable shunt. And the only symptom that we could find retrospectively was that these patients with a severe shift are much more likely to report severe headaches. We didn't find any association with cranial nerve deficits or any motor deficits or anything like that. This is the data we looked at. Can the addition of choroid plexus cauterization prevent post-hemispherectomy hydrocephalus? In our cohort, there were 15 patients that I did not do a choroid plexus cauterization for, generally because there were redo operations and I couldn't properly you know, see the choroid plexus. Usually this can be scarred in with a reoperation. In those patients, about 20% of them developed hydrocephalus requiring a shunt post-op. But in the patients, from the 20 patients that I did perform a choroid plexus cauterization, only one of them, so 5% of them, had a need for a shunt. Otherwise, everything else was very similar between these two groups. Lastly, some pearls and pitfall avoidance in hemispheric surgery. One of the things you can do to try to prevent bone resorption and improve the cosmetic outcome for these patients is considering an osteoplastic craniotomy. Here's where you keep the muscle attachments to the bone so it's not completely devascularized. Minimizing blood loss, very important in young infants. Sometimes you can consider clipping of the MCA branch prior to starting your resection or disconnection. You can also stage the operation, like I talked about, if blood loss becomes an issue. You need to have a great IV access and a great anesthesia team with good communication to be able to do these surgeries very safely. I always resect the temporal lobe. I've never had to rush back for any emergency after a hemispheric surgery, but I have heard of these happen, and so I will never regret removing a temporal lobe. I haven't thus far, but something to always consider. You don't have to resect the temporal lobe, but keep in mind that any swelling in that region can cause compression of the brainstem. If you decide to do a hemispherotomy technique or leave the temporal lobe behind, it is very critical to preserve most of or all of the traversing surface vascular structures. The corpus callosotomy can be quite challenging, finding the interhemispheric fissure. Sometimes people get lost. They may end up on the other side, in the other hemisphere. Not that difficult to do. So the tricks here is consider using neuronavigation or microdoppler to find the ACA. And once you're in that interhemispheric fissure, really try to stay on top of the ACAs and on the vessel to prevent missing some of the connections and ultimately doing an incomplete disconnection. And a few more points here. Pay very careful attention to fronto-basal disconnection. This is the most frequent source of incomplete disconnection, and especially in hemimegalencephalic patients. I've had a patient, for example, had no frontal horn, so very difficult to actually see this. This anatomy may be distorted, so you have to do your best to really stay on those vessels. And you don't want to go too posteriorly, because if you go posteriorly, you have hypothalamic damage, and there are children that have had great seizure outcomes, but hypothalamus has been injured as a result of surgery, and this can lead to significant morbidity. The vein of Galen complex you need to pay extreme attention to when you're doing your posterior disconnection. If you turn and especially end up under the falx and you get into a vein of Galen, you can turn an elegant operation into a disaster. So obviously you don't really want to see it, and you definitely don't want to injure the vein of Galen complex. And lastly, it's a little controversial. I would say most surgeons, including myself, do not resect any of the deep brain structures, routinely thalamus or basal ganglia, as it's been noted to be associated with poor motor outcomes. However, there have been instances where the hemispherectomy is pretty much complete. There's evidence of seizure coming from that one hemisphere, and the surgeons have gone and resected thalamus or basal ganglia, which has led to seizure freedom. So there is the possibility of that being a source of the seizures, but I generally do not routinely resect this and generally don't do it anyway. And I think there's a possibility that resection of these brainstem structures may lead to an increased likelihood of brain shift. Lastly, disconnection of or resection of the insular cortex is a very common cause of persistent seizure. So if you have a child that's continuing to seize, please, you need to make sure that the insular cortex is fully disconnected. And lastly, in terms of preventing hydrocephalus, I think it's really important to keep a ventricular drain, keep it until the CSF is clear. It'll help treat the fevers, aseptic meningitis, and lowers the probability of hydrocephalus. I'd like to acknowledge my entire team at UCLA, our epileptologist. Dr. Gary Mathern was the pediatric epilepsy surgeon for many years at UCLA prior to me. This is Dr. Warwick Peacock, who was his predecessor, and really the first surgeons in the United States that started doing hemispherectomies. He learned this from the South African neurosurgeons. Really, he was one of the pioneers in the technique, bringing it to the United States. Dr. Maynard advanced the field by, you may have heard of the UCLA hemispherectomy technique. It sort of is his advancement and really helping me do the work that I do. Thank you all for your attention, and happy to take any questions.
Thank you so much, Dr. Fallah. It was an amazing lecture. We really appreciate it. I would like to, yes, invite everyone to turn on your videos, and if you have a question or a comment, to please speak. And it was really interesting how the midline shift occurs. I was curious, is there any specific reason for why the shunt leads to more shifts?
Yeah, great question. I don't know. I mean, so one of the controversial points for these patients that develop hydrocephalus is, where to place the shunt, right? So there's a recent survey that was done. 2/3 of surgeons actually prefer placing it in the cavity. The reason why is, that hemisphere is already, I guess, compromised. If you have a complication, if you have a problem with the shunt, it's not going to affect your normal hemisphere. But at the same time, shunts don't really work well in cavities. They sort of sometimes lie against the brain. They may not function as well. And then 1/3 of surgeons, actually, I fall into the third, where usually if there's a need for a shunt, I'd like to place it in the normal hemisphere. I think they just last longer and work better. I was thinking whether the negative pressure because of the shunt will, and especially if there's this cavity, would essentially suck the brain into the cavity. That's our hypothesis. I mean, it's hard to know for sure. And it was hard for us to really compare our experience putting shunts in the cavity versus the normal side, because I want to say all but one of our patients had their shunt on the cavity side, based on the historic UCLA data. So, but it's something that would be interesting to compare across multiple sites to see whether the site of where the shunt is, and that's what we found in our study, the side where the shunt was tended to cause the brain to sort of shift towards that same side.
May I have a question?
Yeah, sure. Go ahead.
Hello, Fallah. It was a great presentation and really great experience with hemispherectomy. But I didn't see in your presentation talking about the different techniques for different pathologies, because hemimegalencephaly usually is much more difficult to remove, to access, to make a hemispherectomy or to make a small hemispherectomy than in a cyst, for instance. Do you think it's necessary to make different or to use different techniques for different pathologies?
That's a great question. There certainly are surgeons that advocate for a different approach. I mean, as you may know, the hemimegalencephaly has a risk factor for requiring a reoperation. So so there are groups that have kind of just do the anatomic upfront for that pathology. We haven't done that. Certainly my approach has kind of been, the functional hemispherectomy up front, regardless of, the pathology. I've gotten quite comfortable, and I think there's a learning curve with this operation. Obviously, I think most people who do this will tell you, especially when they start off, they're much more likely to do an incomplete disconnection. And obviously, after a few, you become quite comfortable. And I kind of do the same operation for everyone. I don't really, and because I do that same operation so often, I've become very comfortable with it. There are some surgeons that also, based on pathology, they may decide to do a vertical approach versus lateral approach. I don't think there's any data or evidence to really say one is better than the other. I think the general recommendation is do what you feel most comfortable in. And also, I'll tell you, there's this move now, several centers, I should say, that are trying to do the endoscopic assisted method. And what they say is, although they recommend starting on the MCA strokes with that technique, they say that they've also applied it to hemimegalencephaly, cortical dysplasia, and they've not had any issues. I can't personally speak about that. I know I visited Dr. Chandra in India and watched him do one. Obviously, he's very good at it. But at the end, I didn't feel like there was a need to switch over to that technique. I think this operation, obviously, the goal, as long as you do it safely and minimize the need for blood transfusion, and complete and achieve a complete disconnection, I think that's your goal of your operation. Obviously, there's technological advancement. We want to do things better and quicker and less invasive. But I personally didn't think that that's a necessary move for all of us to make. But I'm interested to see what happens in the neurosurgical community in the future years.
Another question about hemimegaloencephaly.
Yeah.
Encephalopathy. Well, do you think, I reviewed the literature a couple of years ago, and I felt hemimegaloencephaly had much more hydrocephalus than parencephalic cyst, for instance. Do you feel this? In your series, do you have many more cases of hemimegaloencephaly than what's your experience?
I do too. I must admit, the biggest study in terms of hydrocephalus risk is that paper I showed from Sean Liu, that sort of multi-center study. But I think there's a problem in that data. I think a lot of those patients actually are old UCLA patients, and I've spoken to Dr. Peacock. I showed you his picture in the previous slide. He did a lot of these operations, and he actually told me that he would routinely just shunt these patients post-op. So it wasn't really that they all had hydrocephalus, but he, as part of just preventing that aseptic meningitis and all that, instead of, a lot of us now leave EVDs, he would shunt them all. So that's why those numbers, I think, are quite high. I think most people nowadays would first of all agree that, yes, post-hemispherectomy hydrocephalus happens. It's not 20 or 30%. My experience has certainly been much lower, and I think most people would also say that. Hemimegalencephaly, I think operating on a really young child and their, again, this is all in theory, right? But I think about how intraventricular hemorrhage in a neonate or a young baby can much more easily lead to hydrocephalus than if it were to happen in an adult, right? So there's something about that immature brain, that young brain that you're operating on, that may be more prone to, maybe blood blocking the arachnoid granulations. I'm not sure. So I do agree with you. I think there's a higher probability with it, with hemimegalencephaly or the really, really young kids we operate on. The MCA stroke patients tend to usually be a little bit older, right? So, but I can't tell. We don't have great evidence, to tell us one way or another.
Okay. And what about insula?
Yeah.
There's a lot of controversy how to remove, and if it's really necessary to remove. Do you have any group to compare without removal of the insula to say, wow, it's really necessary? Or have you had any experience where you had to return and remove the insula in one of your patients?
Great question. So I was trained, my residency training, I was in a hospital for sick kids in Toronto with Dr. Rutka, and he would routinely not remove the insula. So and I think a large proportion of those patients were still seizure free. And then later in my training, I went to places. I spent time in Cleveland Clinic, Miami, other places, and they would routinely at least disconnect the insula. So I don't think sure you can get it. And I'll tell you, the other thing I'll tell you is there are patients I've operated on, especially earlier in my series, that the post-op scan doesn't look like a complete disconnection, but the child is seizure-free. So there are instances where you may not have a full disconnection, but it may not matter, and the child's seizure-free. But having said that, I think your goal in these because you can't really predict that preoperatively who's going to be, so your goal for every patient that you're going to do a hemispherectomy on is a complete disconnection. And that involves the insula. There's no reason why to exclude the insula. It is challenging. So for some people, they can try to do little insulotomies where they resect between the MCA vessels. The challenge, obviously, as you know, is that's a very incomplete. That's not a very gratifying. You don't feel like you fully disconnected it if you do that. You can certainly undercut the insula and then just leave it. That's what I was doing. I was undercutting it down to the MCA vessel and then just leaving it there. But talking to Dr. Mather, my senior colleague, he was asking me, if you're really undercutting it, why don't you just coagulate the MCA and just take it out? Like, why do you leave this piece of tissue that's just flopping in there? So I just decided taking it, but I really I don't think there's definitely no comparative studies, but certainly I don't think, because your connections from your insula to your thalamus are still there if you don't fully address the insula. So it's not a complete job.
Yeah, because in the literature, I think the most frequent part of the brain that you have to go back to remove is the frontal-basal region. Usually you don't see in the literature someone saying, wow, I have to go back to remove the insula because of this. Actually, there are some papers, but the frontal-basal is more usual to be left after the surgery.
Yeah, I agree.
And another question is the hemosiderosis. Do you think the VP shunt resolved the problem? Because after the 60s, the hemosiderosis disappeared, and it was about the time the VP shunt started.
Great question. It's interesting. At our recent meeting, we had the epilepsy surgery techniques meeting, and Austria was the last one that I went, and we were, many epilepsy surgeons, and we all kind of made the comment that we're not seeing that anymore. Like the traditional hemosiderosis, where the delayed neurological deficit, the hearing issues, the gait issues, we're not seeing that classic symptom. So I wonder, like you said, is it partially hydrocephalus that's just being better treated? Is it truly an entity anymore? I don't have a good answer to your question, but I think that's something interesting that we have to look at. I certainly see evidence of hemosiderosis on MRI scans in some of these patients, but a vast majority of them don't really look like they have any sort of neurological deterioration, so we don't do anything for it. I don't have a great answer for you. I do think some of at least with the literature, there's some overlap between hydrocephalus and hemosiderosis.
May I have another one? the last question. Okay, it's just, it's a kind of curiosity of mine. It's about the hematomegalencephaly patients. The outcome of them, the long-term outcome then. How many of them become functional? I say they can live by their own. Do you have anyone?
I think,
or they are all instituted for the rest of their life?
Anecdotally, they don't do very well. I can. A lot of these patients develop autism, behavioral issues, and I don't know if it's the end result of it's a larger network problem, or it's the end result of so many seizures on a young, most fragile brain. Some of it may be complications of shunting and shunt complications, infections. I mean, the challenge is there's obviously, these are very rare conditions, so we've never done a great job in sort of collecting meaningful long-term data. We're starting to now just do it as a group, hemispherectomy patients, but you know, like you're alluding to, a patient with MCA stroke is very different than a patient with a large malformation, right? A patient with a very focused problem, you know, MCA stroke, or even Rasmussen's, that's generally just unilateral, very different than a large dysplastic condition. So I think we need to start teasing that apart, and really not, you know, maybe looking at each category separately and not just lumping them all together and saying, you know, these are the outcomes of hemispherectomy, right? You need to have, you know, greater granularity.
Yes, I agree completely with you. There are so different pathologies behind. The outcomes completely different. So it really has to be done.
Yeah, absolutely.
Luiz, you want to say anything?
Yes, thank you so much, Dr. Fallah, and thank you for your participation, Dr. Almeida. So if anyone has any other questions, otherwise now we could end the lecture, and we are going to have now, I'll change to Portuguese. Nós vamos ter uma apresentação da BR Surgery, agora nesses últimos minutos, e agora eu deixo a palavra com o Roberto. Thank you so much, Dr. Fallah. It was an amazing opportunity for all of us.
Thank you.
Thank you so much.
Thank you.
Thank you very much.
Boa noite. Eu gostaria de agradecer a oportunidade de poder apresentar para vocês um pouco sobre a BR Surgery. Vou fazer rapidamente aí uma apresentação sobre os desafios que nós estamos todos tendo com a nova realidade do mercado. E, bom, eu vou diretamente ao assunto aqui. Então, o ponto principal aqui é que a Covid, a coronavírus, realmente afetou o mercado. Houve uma pressão para as seguradoras segurar seus custos, uma migração que já é vista para os planos verticais, a teleconsulta, como é que ela impactou o mercado como um todo, a pressão de custos também está aumentando do ponto de vista das empresas por conta da redução do volume, a possibilidade de fusão e consolidação do mercado, e nesse ambiente todo, como fica a questão dos médicos, né, dos médicos cirurgiões e médicos em geral. Estou colocando um gráfico rapidamente para mostrar o tamanho do mercado brasileiro, que tem gastos privados da ordem de 56%, gastos públicos de 43%, de cerca de 10% do PIB. Então é um mercado realmente bastante grande e que vai sofrer uma mudança bastante importante nesses próximos meses. Aqui é uma progressão, acho que todo mundo já conhece esse gráfico, que é o de que a nossa base estava em 47 milhões de usuários de plano de saúde e que possivelmente as previsões aí vão se consolidar para algo em 40 a 39 milhões de segurados, né? E o que significa isso? Essa página aqui é um pouco representativa, que o que está acontecendo no mercado, uma migração das operadoras horizontais para as verticais, um ganho de participação da Prevent Senior, da Intermédica, da Afiliado, e são justamente as operadoras que tipicamente não têm os médicos como empresários, têm o médico como um funcionário ou como um parceiro, né? E isso aqui mostra o ganho e o avanço dessas operadoras, principalmente. Você vê que o Bradesco continua como sendo a maior operadora do Brasil, a Amil em segundo, Sul América em terceiro, mas logo em quarto a gente vê a Notre Dame, que opera praticamente só em São Paulo, a Apivida com 4% também, que sim opera no Nordeste, está entrando em São Paulo, e a Prevent Senior com 2%. Então, uma incrível ganho e mudança do mercado em muito pouco tempo. E isso provavelmente vai acelerar neste ano e nos anos que virão, por uma questão básica de redução de segurados, necessidade de redução de preços que a gente já está enxergando para a retenção desses segurados em cada uma dessas empresas, né? E acho que o que a gente, quando fala de custos, a questão hospitalar representa aí cerca de 50% dos custos das operadoras, e nesses custos nós estamos falando aí de 43% de OPME, de 20% cerca de diagnósticos complexos. Então a gente vê como é que isso é concentrado, sendo que o resto significa 35% dos custos do plano de saúde. Então as operadoras verticalizadas estão em risco, estão colocando em risco o mercado. Os RHs pagam hoje 70% dos planos privados, então essas empresas vão migrar rapidamente para uma solução mais barata, e todo o ecossistema está baseado em cima de operadoras horizontalizadas, que justamente é uma questão. Então, nos Estados Unidos, essa questão de custos e de elemento de interesses foi resolvida há 40 anos, né? Então, a gente vê aí um gráfico, talvez bastante conhecido para alguns, que que em 95 houve o começo da operação dos hospitais DIA, ou ASCs, Ambulatory Surgical Centers, onde começaram a ter uma participação bastante importante do número de cirurgias feitas no total, né? Hoje esse número já está acima de 80%, 80% de cirurgias são feitas fora do hospital tradicional, e esse número de cirurgias mais complexas está baixando, até por conta de que a tecnologia está permitindo que essas empresas, nesses hospitais DIA, consigam cada vez aumentar mais a sua participação. Uma coisa importante dizer é por que isso aconteceu, né? Além da questão que os hospitais DIA são muito mais baratos, existe uma facilitação do relacionamento entre a fonte pagadora. Hoje a fonte pagadora do lado esquerdo, que a gente enxerga, que ela lida com 3 players importantes. Os hospitais, que detêm aí uma conta, uma participação da conta que vai aí de 30%, 40%, 60%, as empresas de materiais médicos, OPMEs, assim por diante, de 40%, 70%, que é uma participação muitas vezes para cirurgias mais complexas e médias, que é até maior do que do hospital, e o médico, que na verdade detém toda a coordenação do cuidado com a identificação da necessidade do paciente de ter uma terapia cirúrgica, ele detém uma participação de 5% a 10% da conta médica, né? Então a gente vê que existe aí uma conta aberta e uma complexidade bastante grande nesse relacionamento de 4 partes, né? A fonte pagadora com essas 3 aqui. Quando a gente muda para um modelo de ASC, existe então uma facilitação do relacionamento que é entre 2 empresas, que é o ASC, onde o ASC fez acordos fechados com médicos, na maior parte. Nos Estados Unidos, 80% dos ASCs têm sociedade com os médicos. E aí tem um alinhamento muito claro do processo, onde não só se resolve a questão de preço, mas as questões do que vai incluir na conduta médica. Então é simplificado esse processo de relacionamento. Então esse gráfico é o mais assim, informativo do porquê que o ASC funcionou nos Estados Unidos, né? Então esse problema foi resolvido. O ASC ele tem, de média, 60% do custo a menor do que o custo de um hospital tradicional, porque não tem UTI, não tem emergência e não lida com os procedimentos complexos que custam mais caro normalmente. Então é 100% ambulatorial para pacientes ASA 1, ASA 2 e um bundle, ou seja, um pacote fechado. E geralmente existe um centro especializado, ora um ASC focado em ortopedia, neurocirurgia ou oftalmo, mas geralmente eles são focados, especializados, o que faz com que exista inclusive uma qualidade de terapia melhor do que um hospital que é generalista, né? Eu queria mostrar um pouco desse modelo que a gente implantou no Brasil, que é uma cópia praticamente do modelo americano. Então existe uma estrutura, uma ambientação bastante quente para os usuários, tanto os médicos que são sócios quanto os pacientes, né? Uma estrutura tecnologicamente avançada e uma estrutura também de coworking, a gente chama de coworking cirúrgico e médico, clínico, que permite com que o médico não se preocupe tanto com as questões administrativas. A gente toma conta tanto do consultório, que acaba sendo ofertado como um coworking, né? Ou seja, o médico trabalha naquele ou naqueles endereços. Hoje nós estamos contando com 3 unidades de serviços para ambulatórios e mais um hospital, né? Uma coisa importante também dizer é como é que funciona essa conta, onde a gente divide as soluções de pacote. Então, o pacote, na verdade, tem tudo, mas, na verdade, existe toda a quebra de custos aqui. Então, a OPMI está aqui dentro, junto com a MatchMed, foi feita uma adequação desses custos, uma negociação, e o médico tem não apenas a participação dos honorários médicos dele, normal, que são faturados de forma direta, mas uma participação dos lucros do hospital, porque ele é sócio do hospital. Para a operadora, ela enxerga, na verdade, duas faturas, uma fatura típica que ela já tem, que é a fatura dos honorários médicos, mais uma solução de pacote fechado, onde a gente fecha não apenas o custo hospitalar, mas o risco de uma eventual intercorrência à UTI, e pelo fato de a gente integrar toda uma estrutura que permite melhorar o desfecho, a gente garante também o risco da reoperação, do reop, né? Então, hoje, um hospital é baseado em fee-for-service, no modelo ASC, é um pacote com desconto que é da ordem de 10% a 50% de uma redução de custo. Uma bariátrica, aí, só para dar um exemplo, hoje um hospital de grande porte pode custar seus 40, 50 mil reais. Hoje uma bariátrica na BR custa entre 15 e 18 mil reais. Só para dar uma ideia mais ou menos do que significa a diferença de custos aí. Então, numa solução hoje atual, os honorários médicos são os únicos, as receitas básicas do médico. Quando ele vira sócio do hospital, ele tem honorário médico, ele tem uma margem hospitalar, ele tem um ganho tributário, porque a empresa dele vira efetivamente um hospital, então paga metade do imposto. Ele tem um ganho imobiliário, porque ele é sócio de uma empresa, e através de um fundo que é imobiliário. Ele tem um poder de negociação porque tem vários médicos que agora podem exercer uma pressão maior do que simplesmente um médico que está solitário ali na sua negociação com a fonte pagadora. Aqui eu vou passar rapidamente por isso, mas é só para ter uma ideia mais ou menos o que significa isso em dinheiro, né? Quer dizer, ou seja, hoje se a gente está falando de uma consulta média de R$200, nesse exemplo aqui, né, e o médico faz eventualmente 200 consultas por mês, ele teria uma receita de 40 mil reais, e se por acaso a margem dos honorários fossem 6 mil reais por cirurgia, ele teria mais 60. Então aquela empresa médica dele teria 100 mil reais de receita. Assim, desconta todos os impostos, os custos com condomínio, consultório, tudo, ele teria uma despesa subtraída aí para um ganho de 65 mil reais. Esse seria um caso, assim, de novo, imaginário, mas diria não tão distante da neurocirurgia. Quando ele muda para o modelo BR Surgery, ele mantém essas receitas aqui, mas ele ganha uma média aí de 10% a 30% da conta médica. E aí esse ganho aqui foi colocado em 7 mil reais, que é, por exemplo, no caso da bariátrica, esse é o valor. E aí ele tem um aumento da receita, só que ele paga metade do imposto, né? E ele não tem mais os custos totais do consultório, os outros custos são fixos, não tem mais glosa, porque a priori no pacote não tem glosa, e aí você teria aí um ganho quase que dobrado, mesmo depois de ter pago o valor do investimento de ser sócio no hospital, em parcela, que está com R$5.800, na verdade o custo nosso do investimento é da ordem de R$295 mil, e você compra um pedaço do hospital por esse valor. Então aqui só rapidamente é um histórico da nossa empresa. A gente fundou a empresa em setembro de 2018, fizemos a inauguração do ambulatório em junho de 2019, e em setembro a gente estava fazendo a nossa primeira cirurgia, em janeiro a gente inaugurou nosso hospital na saúde. Agora nós criamos um fundo de investimento imobiliário, criamos a BR Clinics, que é uma empresa focada em policlínicas, com 3 unidades, e a gente está agora finalizando os credenciamentos e com uma série de contratos com empresas de todo tipo. Inclusive nós fechamos uma recentemente para fazer financiamento de cirurgias para aquelas pessoas que não têm plano de saúde. Então aqui é um pouco do nosso resumo. Hoje é um hospital totalmente operacional, tem 4 salas cirúrgicas, mas a gente tem não só o espaço, mas o intuito de fazer mais 4 salas, inclusive uma delas será com uma tomografia com procedimentos intracirúrgicos, um centro de repouso pós-anestésico, sala de emergência, 8 salas privativas, 34 leitos, toda uma estrutura pronta para de fato fazer amparar o paciente de neurocirurgia principalmente no caso de coluna e funcional. Então são os nossos dois focos na neurocirurgia. Isso aqui é para mostrar um pouco a estrutura do nosso negócio, que é um pouco diferente, porque o médico ele é sócio não através da sua empresa, mas através de um fundo de investimento. Isso protege que o médico eventualmente tenha algum tipo de risco com outro médico, né, que eventualmente teve um problema, ou até com problemas com o hospital, porque ele é cotista de um fundo através da Bovespa mesmo, né? Então esse é o modelo que a gente tropicalizou, modelo americano, que no caso nos Estados Unidos ele é sócio direto do ESI. Aqui a gente fez esse modelo um pouco mais sofisticado, que é um fundo de investimento gerenciado por empresas de gestão, de administração de bens, gestoras, assim por diante, para que dá essa proteção e essa governança para que os médicos não tenham a preocupação de que alguém está gerenciando mal o negócio deles. Nós somos um operador do hospital, os gestores, administradores, custodiantes ficam observando essa nossa operação e dando todos os esclarecimentos e governança e relatórios para os médicos que são sócios, que nesse caso podem se focar na medicina, né? Focar tirando fora essas questões administrativas. Que é um pouco do resumo do que a gente faz para médicos. Nós somos um coworking cirúrgico e clínico, né? Então a gente faz gestão administrativa, pagamento, reembolso, essa parte contábil. As locações, na verdade, são feitas por uso. A gente, inclusive, tem uma série de soluções de marketing pessoal. Toda a parte de gestão de risco a gente faz na empresa, então seguros, essa questão de risco de intercorrência, esses hospitais de retaguarda, tudo está dentro do nosso sistema. E a gente ainda por cima tem toda uma parte de informática bastante avançada, tanto na parte hospitalar, prontuário médico, como aplicativos para o paciente, que melhoram a qualidade da assistência ao paciente. Então nós realmente fazemos tudo o que é necessário e caso haja uma necessidade adicional, a gente tem feito bastante evoluções por contribuições do médico. Olha, puxa, vocês não tinham isso como solução, mas eu estou dando uma ideia aqui para que vocês possam fazer, porque eu acho que é importante. Então a gente fez várias evoluções, principalmente no caso da neurologia, onde exige uma gestão terapêutica multiprofissional. Nós estamos integrando uma série dessas atividades com um aplicativo que serve tanto ao paciente quanto à família do paciente, para que ele possa enxergar como a terapia dele está caminhando, principalmente nas terapias de doenças crônicas e neurodegenerativas. Então, aqui o resumo da apresentação, que eu estou acabando esse último slide. A BRSD vem no Brasil para mudar. Nosso modelo é um modelo que a gente acredita ser vencedor no momento de crise, como nós estamos vivendo, onde o médico precisa de uma musculatura para poder suportar essas pressões do mercado. E, além do mais, estamos lutando junto com um grupo bastante robusto de médicos, hoje líderes nas suas áreas. Nós estamos trabalhando em 7 segmentos. O segmento de neurologia, neurocirurgia é um dos principais, ortopedia, bucomaxilo, gastroenterologia, cabeça-pescoço, urologia são os outros segmentos. Então, está aqui a minha apresentação, fico à disposição para qualquer tipo de dúvidas, tanto aqui como online. Meu telefone e contatos estão disponibilizados aqui na apresentação depois, tá? Muito obrigado e bom, agradeço aí, que fico à disposição para qualquer tipo de pergunta nesse momento.
Obrigado, Roberto. Se ninguém tiver mais nenhuma pergunta, podemos finalizar aí a sessão, o nosso encontro científico de hoje. E em breve teremos uma próxima, então fiquem ligados. Muito obrigado pela participação hoje.